Dr. Holly Rizzo here. Welcome back to our pediatric dental lecture series. Today we'll be discussing non-pharmacological behavior management. So generally there are three types of pediatric behavior. First we have cooperative, then uncooperative, and potentially cooperative. We'll go through each of these one by one and discuss some behavior management techniques you can use that are non-pharmacologic in nature. In pediatric patients with cooperative behavior, we may see the patient being communicative, comprehending what you're saying to them, and likely will be collaborative and very relaxed. We'll also see good rapport between them and the dental professionals and the dental team at the office. Most importantly, they'll have a willingness to cooperate, such as asking them to sit and open their mouth for examination, and instructions are followed with minimal apprehension. Contrastingly, for patients with uncooperative behavior, this patient may not be communicative or non comprehending. There may be crying and screaming and a general unwillingness to cooperate. Some examples of uncooperative behavior include infants with limited understanding and language skills, and patients who have developmental disabilities and may have difficulty with cooperation and adapting to new routines or environments. These characteristics are opposite of what is seen in cooperative behavior. Pediatric patients can also exhibit potentially cooperative behavior, and I've found that this is one of the most rewarding patient populations to work with as you can really change or improve their outlook on dental visits. Being pre-cooperative suggests that a child has the ability to cooperate and is capable of exhibiting or learning appropriate behavior. However, they may demonstrate behavior that serves to be disruptive in the dental environment at first. This behavior can be modified, like I mentioned before. So there are some subclassifications within potentially cooperative behavior. This includes avoidant, uncontrolled behavior, defiant behavior, timid, tense cooperative behavior, and whining behavior. So, avoidant behavior involves pediatric patients who actively avoid the dental office and regular routine dental care. This patient would avoid the primary operator, dental staff, and the office overall. Oftentimes, in my experience, this might look like a child hiding in the waiting room or holding the parent's hand tightly as they're walking into the operatory. Next, we have uncontrolled behavior. This is typically seen in young children between 3 and 6. A tantrum is a common characteristic of this behavior and involves loud crying with or without tears, physical lashing out, and flailing of the hands and legs. Defiant behavior can be seen in children of any age. This is typically with patients who are overindulged and stubborn, which are common characteristics. It's similar to kids saying, I don't want to, or I don't have to, or I won't. These kids do not like to be advised by adults or follow given instructions in a show of stubbornness. Some examples of defiant behavior include clenching teeth or tip lips tightly together during an intraoral exam, or refusing to sit in a chair for a dental examination. Next, we have timid behavior. Timid behavior can be seen in children who are 3 to 6 years old. It has the typical feature of shielding, which can be defined as when a child hides behind their parent. This behavior may worsen and turn into uncontrolled behavior, so it's important to establish trust and good rapport with patients who exhibit timid behavior and ensure their comfort in the dental setting. I find it's best with these patients to use techniques like tell, show, do, and taking the visit slowly to make them as comfortable as possible. Maybe for the first visit, we let them lay on their parent's lap in the dental chair for increased comfort, or have the parent pull up a chair next to them to make sure they feel safe. Tense cooperative behavior is typically seen in patients who are over 7 years old. Although the patient attempts to cooperate, they may still be tense or stiff during procedures, demonstrating nervousness. This is seen in tense or stiff body language, such as white knuckles, a tremor in the voice, perspiration, and generalized nervousness. Finally, we have patients who exhibit whining behavior. There's a continuous whining throughout the entire visit, and there may be frequent complaints of pain even without any stimulus. This is a very controlled crying that the children will give you, and it's usually without tears. These patients will require a lot of patience from dentists and dental staff. A tool we often use in pediatrics for calibration is the Frankl rating scale. The Frankl rating scale was developed in 1962 for the classification of children's behavior into four categories. So, rank 1 is definitely negative. This involves patients that are showing refusal, forceful crying, or unwillingness to cooperate. Frankl 2 is a negative resistance. This involves patients who show reluctance, are generally uncooperative, but less pronounced pessimism in these patients. Frankl 3 would be a positive acceptance. This involves patients having some acceptance cooperation, And they're reserved but have a general willingness to cooperate. And finally, we have Frankl 4, which is your ideal pediatric patient. They're definitely positive, and this involves patients being interested, cooperative, and enthusiastic during treatment. So, there are some outside variables that may affect pediatric behavior. So, first, we'll start with parental behavior. This means that parents themselves may dislike going to the dentist, and children can learn and follow this behavior. One way I've seen this during dental visits is when the parents will say phrases like, "When I go to the dentist, I hate when they put the needle in my gums," or "I don't even like the dentist, so I get why my child is scared." Another factor that might influence this is past dental or medical experiences. This is especially notable in pediatric patients with significant medical history, such as oncology treatment for leukemia or other pediatric cancers. Understandably, these children may be more mistrusting or fearful of medical and dental providers. We also often see parents who come in with a chief concern that their child is traumatized from a previous dental visit. In these situations, it's essential to demonstrate patience with these children and utilize techniques like tell, show, do, or have the child hold a mirror during their dental exams or cleanings to show them that these visits don't have to be scary. Another factor that can affect pediatric behavior is socioeconomic factors. This includes costs of dentistry, which is a common concern, which may cause avoidance of dental visits. This can increase patient anxiety as well. Next, we have cultural and ethnic factors. In some cultures, it's only emphasized to come to the dentist when the child is already in pain from deep cavities, and this may require more invasive procedures to help these children. This can cause anxiety as the child's only experience with the dentist would be challenging restorative visits, as they aren't getting exposure to simple and easy visits like exams and cleanings. Next, we have sibling anecdotes, such as older siblings telling scary stories about the dentist to their young sibling, which will negatively affect their perspectives. So, there are different management strategies for different behavior seen in children, and we can customize this to each child depending on their behavior. So, first, I'll start with pre visit imagery. This is an example that involves providing positive visual cues around the dental office to increase positive association to dental care and the dental setting. It's indicated for any patient and may be implemented as part of familiarization or as an intervention visit. This may include a video on your office's website that has a walkthrough of what your dental visit looks like, so the child may become familiar with what to expect during their dental visit. This is especially useful for neurodivergent children who may struggle with new environments and experiences. Next, we have direct observation. This may include watching a video about the procedure or explaining the procedure as it's performed on a positive role model, like a sibling or a parent. I've also used this with a patient's stuffed animal or toy. You can prop them up in the dental chair and demonstrate counting the teeth with a mirror and explorer as well as brushing. Next, we have tell, show, do, which I've already mentioned a few times in this PowerPoint. This is one of my favorite techniques. So, this is commonly used providing a verbal explanation, a demonstration, and execution of the procedure at hand. It allows patients to become familiar with the tools and lessen their anxiety. Children like to be curious, involved, and ask questions. So, for restorative treatment, I'll describe the handpieces as electric toothbrushes and even let the child step on the rheostat and feel the vibration on their finger, without the burr in the handpiece, of course, to make the experience less intimidating for them. Finally, we have distraction. This utilizes attempts to divert the patient's attention from potentially fearful situations. This may include music, TVs, toys, or other methods. I'll often play a guessing game with children, such as, "Let's guess your favorite ice cream flavor," throughout the restorative visits, where they can answer my questions with a thumbs up or a thumbs down. And this keeps the kiddos distracted and also helps them have fun at the dental visits. And it helps me have fun too. Some more non pharmacological strategies for behavior management include systemic desensitization, which involves gradual and more frequent exposures to components of dental procedures to minimize anxiety. This can be very beneficial for children with special healthcare needs. Seeing children every 3 months versus 6 months can make children more comfortable in the environment and with the provider. With desensitization, I've seen 2-year-olds go from kicking and screaming in the parent's lap to tolerating restorative treatment in the dental chair in under a year. This is so rewarding as a pediatric dentist. We can also adapt the sensory environment to reduce fear in patients with dental anxiety or in patients with our special needs. This may include using a weighted blanket or dimmed lighting or headphones. For animal assisted therapy, trained animals may be introduced to the dental setting to reduce anxiety. However, one should consider infection control protocol and make sure that patients and parents are comfortable with this prior to introduction due to possible allergies or fear of animals. Another wonderful strategy includes picture exchange communication system, which utilizes picture cards to facilitate communication with visual representations. It's oftentimes indicated for patients who may not be able to communicate verbally. So let's go through a few questions. So for question one, we have a 7-year-old male who says they don't want to be at the dentist. This patient has fair oral hygiene, and in our current findings, they remain quiet and hides behind mom upon entry to the dental office. Which of the following is the most likely behavior that the patient is exhibiting? I'll give you a moment to pause so you can think about this question. So the correct answer to this question would be option C, which is timid behavior. Since this patient is exhibiting shielding, which is hiding behind a parent, and this is commonly seen in timid behavior. For question two, we have a 5-year-old female whose chief complaint is, I want to go home. In the background, we have a history of poor oral hygiene. For current findings, we have loud crying, flailing arms and legs. So what is the most likely behavior that this patient is exhibiting? And I'll give you a moment to pause and think about this question. So the answer to this question would be option D, uncontrolled behavior. Since this patient is exhibiting loud crying and flailing arms and legs, which are a sign of a tantrum, this is commonly seen in uncontrolled behavior. So thanks for joining us. I hope you learned something today. Just to summarize, some different types of behaviors will be discussed today, including cooperative, uncooperative, and potentially cooperative behaviors that can be seen in children. Additionally, we discussed the subclassification of potentially cooperative, which includes avoidance, uncontrolled, defiant, timid, tense cooperative, and whining behavior. We discussed some diverse strategies that can be applied to manage children's behavior, and any of these can be applied to any of the behaviors that we discussed earlier. So thanks again for joining, and we'll see you next time.